Thank you, Luce. Good evening, everyone, and welcome to eUROGEN's webinar programme. Just before we go into this evening's webinar, I'll just take a couple of minutes to explain a few of the activities of the ERNs because they're still not very widely known. So there are 24 European reference networks and they all deal with rare and complex diseases and conditions, and they were created by the European Commission in 2017. And the aim for us as a network is to deliver faster specialist evaluation for those patients with the rare or complex diseases. One of the main activities is we collaborate doing virtual consultations. So any doctor working in any country in the EU can ask for a consultation with us, with our network, with the experts who are dealing with that particular disease area and perhaps are treating high numbers of those patients. And this is free and fully available. So if you're interested in discussing one of your cases, please contact us via the website. We'd be really pleased to hear from you. And we also collaborate in education and training activities like this webinar, and we also have an ERN clinical exchange programme so that we can send members, any member of the MDT, to any members of our network. So that's the main activities. Please contact us with suggestions for future webinar topics or virtual consultations or anything else. We'd be very, very pleased to hear from you. So this evening's webinar is joint with another ERN, ERNICA, which deals with congenital digestive and gastrointestinal anomalies. So we're very pleased to deliver some of these ERNs jointly with ERNICA. The presenter this evening is Marieke Witvliet, and she's from a healthcare provider in Utrecht. And it's going to be chaired by Ivo de Blaauw, our very own from the EUROGEN network, and he leads the anorectal malformations disease area group for our network. So Ivo and Marieke, really thank you so much for sharing your expertise with us this evening, and you're going to talk to us about the quality of life for patients with Hirschsprung's disease. So thank you both very much, and you have the floor.
Hello Marieke, hello everyone. I'm very happy and to introduce you, and I'm almost honored to introduce you because you have so much knowledge on quality of life. I've done a lot of research. We've been working together for several years now together in a colorectal center, treating the patients together. And I know you as a very dedicated surgeon, but I also know you as someone who knows a lot about the quality of life of both patients with Hirschsprung's disease and anorectal malformations, because years ago you did a PhD, and I'm very excited that you can share us your knowledge about it, and that we can have some kind of a discussion on quality of life, what we can do with it in our daily clinical practice. But I'll leave most of the floor and most of the time for you, so please continue, and the floor is yours.
Thank you, Ivo, for the introduction. I'll show my screen, and first of all, I want to say that I'm actually really honored. I'll see if it works. Yes, you see my screen now. Thank you, and I'm really honored to be able to speak to you all tonight about the quality of life in Hirschsprung's disease. But before I actually will start my my presentation, I would like to ask you some questions. They probably are going to be in the poll, so I hope that we will see that. So, do you systematically evaluate quality of life in all your patients?
So I'll wait a few more seconds to close the poll. Please vote if you didn't already.
And it is
No,
anonymous, so everybody can vote.
Yeah,
Don't be
everybody
afraid.
can vote.
Don't hesitate. Just be honest. It's no problem at all.
Then I will now close the poll. In total, 59 people said yes, and 32 said no to this poll.
All right. The next one, do you have a multidisciplinary team during follow-up of patients with Hirschsprung's disease in your hospital? I just like these questions to ask to you because in my hospital, it was not as normal as we always think in webinars or in congresses. Everyone is saying you need to have a multidisciplinary team, and everyone says yes, 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 but I know how difficult it is to get one.
Yes, from our audience, 71% said yes and 25% said no.
Perfect.
Great.
Do you have outpatient follow-up until your patients are 18 years old? Or will you stop before?
Most people are voting. Very good. Thank you. And 70% of the attendees says yes, and 26 says no.
Good.
That's interesting, but it's very good as well.
Yeah.
Yeah. Do you have the transition to care in adult life arranged in your hospital? Is there a standard program which they will follow?
Well, if everybody says yes now, then we can stop the webinar.
Then we
Okay,
have a free
Marieke?
evening. Yeah, then we can go home.
Well, now almost half of the people says yes. It's 58%.
Very good.
There's room for
Well,
discussion.
thank you for, yeah, that's good for the discussion. And thank you for all the answers, because it means that I think it's good that you will hear the data, which I will tell you in the next 20 to 30 minutes. And then you can take that home with you and take that to your hospital to see what are the things that you find important to arrange in your hospital. But first, I would like to begin with a short introduction on quality of life. Quality of life has become an important topic since the beginning of the 21st century. In the 20th century, everyone was busy creating the best possible operations. And now we have those. And of course, they're evolving all the time as well. But we have time now to think about the quality of life in later life. So the first studies on this topic in this patient group started actually in the first year of this millennium. And in recent years, more and more studies are published. And many patients worldwide participated in these studies. I think in every country already studies are done, so a lot of your patients might have also participated. But what are we thinking about now? What is quality of life actually? Well, there is a definition from the WHO which says it's an individual's perception of his or her position in life in the context of the culture and value systems in which he or she lives and in relation to his or her goals, expectations, standards, and concerns. Well, what does that mean? Because that's quite a difficult definition. It actually means that quality of life is one's evaluation of his or her functioning in a wide range of areas. So therefore, it's actually a subjective it's subjective and it refers to satisfaction. And since quality of life refers to satisfaction or dissatisfaction with functioning, it can vary over time, depending on your own life events or due to coping strategies or just due to growing up. And it's the I want to give an example for it, just a normal example. When there's a patient with Hirschsprung's disease and he's actually fecally incontinent all the time and decides whenever in their life, I want a definitive stoma. A lot of people will say, well, that's terrible. You will have a stoma and that must be terrible for you. But the patient is actually better off and the quality of life of the patient will probably go up. So the generic quality of life refers to satisfaction, and that patient is more satisfied with a stoma when he can do everything instead of being fecally incontinent. Then there is another part of quality of life, which is health-related quality of life. That is all those aspects from one's life that are affected by the disease and the person suffers from. These questions are different. They're just not asking about satisfaction, but they're more objective. Is your incontinence for feces affecting your daily routine and life, for example? Do you feel sad because of the fact that you're incontinent for feces? So it's definitely more objective. And in health-related quality of life, you also have two types of quality of life which you can investigate. One is, again, generic and one is disease-specific. Looking at Hirschsprung's disease, the disease-specific questionnaire you can use is the HQoL. And that's actually the only disease-specific questionnaire. Otherwise, you will have generic health-related quality of life, which most of the time is measured with the PET score, you probably know, or the CHQ. But when you want to perform quality of life research, what should you do actually? And that is, I think before you start, that's the most important thing, because you have to define first what question do you want to have answered. Do you want to investigate the generic quality of life, so the satisfaction or dissatisfaction of your patient, or do you want to investigate health-related quality of life? And then the next step should be, which tools do you need to get your answers? There are different tools you can use. You can use questionnaires or you can use interviews. Both have, of course, advantages and disadvantages. For the questionnaires, advantages is that there are objective answers, they're anonymous. People can do it in their own time. But the disadvantage is a low response rate. We've done in the Netherlands several studies with questionnaires, and you're actually quite happy when you have a response rate in between 50 to 70%. That is very good. An interview has a big advantage because it has a relatively high response rate. But the disadvantage is that answers can be influenced by the interviewer's way of asking the question. And socially correct answers are given when the interview is done by the caregiver. You should not be surprised how patients want to tell their doctor that they're doing good, they're doing fine, and they did a good job. But that's not always the case when someone else is asking the same question. My personal favorite are the questionnaires. The hypothesis that I had when I started my PhD several years ago and finished it was that functional problems of the patient can actually give parental stress, anxiety, and a lower quality of life in parents and in patients. And on that account, the parental stress and anxiety and the lower quality of life could actually be of influence of the functional problems of the patient. So therefore, it's a circle, and you need to be able to intervene maybe in this circle to make quality of life good for everyone. What I just told you already, that there are different aspects of quality of life. So we can talk about generic quality of life and generic or disease-specific health-related quality of life. But there's a third one I did want to discuss with you tonight as well, and that is sexuality. It's a part which is not often talked about in the doctor's room, but it's very important with people who've had surgery in the pelvic floor, and it's something that can really give problems as well. In the next 15 minutes, I will give an overview of the recent literature that was published actually from the last 7 years, and I tried to focus on studies that were only on Hirschsprung's disease. Like you all know, a lot of times these studies are combined, Hirschsprung's disease and anorectal malformation. There are a few studies with both, but I did not want to get rid of those studies for you. So we start with the quality of life or the health-related quality of life studies. The first study was actually just published in April this year, and it's a Dutch study from Amsterdam, generic and disease-specific health-related quality of life in patients with Hirschsprung's disease, and it was a systematic review and meta-analysis. In the systematic review, there are 17 articles with 1,137 patients, and in the meta-analysis, 15 articles with more than 1,000 patients. All these patients ranged from 0 to 21 years old. They said that actually as a conclusion that there was no evidence for a lower generic related quality of life compared to controls. And this generic health-related quality of life was not dependent of sex or if the questionnaire was self-reported or parent proxy. They did see that disease-specific complaints impaired the physical health-related quality of life, but not the psychosocial and social domains of the health-related quality of life. The next study was also from the Netherlands, was a nationwide cross-sectional study, which was actually asking about familial experience with Hirschsprung's disease. Does that improve the patient's ability to cope with his or her disease? 336 patients were analyzed, all 8 years and older. About 16% had a family member with Hirschsprung's disease, which is about the same as the worldwide percentage, which is in between 16 and 18%. And the quality of life of the pediatric patients was actually comparable, so familial or not familial. But in adult patients, energy, fatigue, thinking, learning, concentration, and work capacity were actually significantly better in the patient who had Hirschsprung's disease of the rectosigmoid when they had a family member with HD, despite the fact that in that same group, there were more functional problems. There was more constipation. So they concluded in this study that families who are familiar with HD provide a better environment for developing good coping strategies with which the patient can handle the disease better and grow up better, actually handling his or her disease. Oh, sorry. Then the next study, which was from Great Ormond Street, a single center study on long-term surgical and patient-reported outcomes of Hirschsprung's disease. They said that the bowel function was reduced in patients, but when patients were growing older, the prevalence and severity of fecal soiling and awareness of it improved actually with age. Health-related quality of life outcomes strongly correlated with functional outcome, with 42% of the children reporting reduction in their PET-SCOL score. And a poor bowel outcome, therefore, was strongly associated with impaired quality of life. In the adults, the Gigli scores were more often reduced when they had extensive disease, so long segment or total colonic. The SF36 scores, which were the generic quality of life, were reduced in most domains, especially for females in general health and social well-being. They concluded that long-term support and early recognition is definitely needed in all these patients. We go back to the Netherlands with a study on also the long-term functional outcomes and quality of life. What they saw was that the prevalence of constipation was comparable in pediatric and adult patients, but was also comparable to controls. But compared with controls, adults with Hirschsprung's disease experienced more straining and incomplete evacuation. The prevalence of fecal incontinence, most commonly soiling, was lower in adults than in children with Hirschsprung's disease. So again, they also concluded that the older the patient gets, the less severe the functional problems become. But it still remained higher than in controls. And the children with poor functional outcomes scored significantly lower in several quality of life domains, such as self-esteem, behavior, general health. Self-efficacy is also a very important topic. And this is not seen in adult patients anymore. From Finland, a study on social morbidity in relation to bowel functional outcomes and quality of life. Patients with severe Hirschsprung's disease are at risk of social restrictions from impairment of bowel function despite their surgical treatments. And the quality of life outcome in adulthood, they saw that would maybe more influenced by self-perceptions of the illness formed already in childhood than only the disease-specific factors. And social morbidity experienced during childhood may continue to affect emotional domains of quality of life in later life, despite improvements in the bowel function when the children reach adulthood. So this conclusion says actually that you should, maybe you have a point during childhood or adolescence to intervene. We go to Australia now, to Melbourne, the long-term quality of life of adolescents with Hirschsprung's disease. They were interviewed and questionnaires were answered. They had a median age of 14.5 years old. And there were no difference in overall, so generic quality of life compared to controls. Disease-specific questionnaires revealed reduced quality of life in patients. 17% of the children actually stopped socializing, and 42% of the parents experienced some degree of anxiety or depression. Fecal incontinence, constipation, and dysfunctional elimination all negatively correlated with the quality of life scores, the health-related quality of life scores in several domains. And also they concluded that adequate follow-up for patients and their families should be in a multidisciplinary approach. One of the last studies is about the total colonic aganglionosis, so a different patient group. We investigated here in the Netherlands all the patients who were treated for total colonic aganglionosis between 1995 and 2015. We had 35 patients who were 4 years or older, and only 18, but it was 51% responded to the questionnaires. They all had Duhamel and Rabine procedures. And what we saw that 65% had constipation, 47% fecal incontinence, and 53% soiling. 18% was on bowel management, and I mean with bowel management laxatives or rectal flushes, and 29% had adaptive diet only. They had worse perception of their general health and were more limited by bodily pain and discomfort compared to their healthy peers. And they said that their quality of life, their health-related quality of life, is mostly influenced by diarrhea and other physical symptoms. The bowel function and quality of life only after transanal endorectal pull-through for Hirschsprung's showed us that compared with matched peers, significant impairment of fecal control prevails after TERPT in HD patients during childhood, but also here the symptoms diminish with age. And although overall generic quality of life appeared comparable to controls, impairment of emotional and sexual domains may prevail in adulthood. Now 4 studies on sexuality I want to show you. The first 2 are from the Netherlands. The first from Rotterdam, which studied 36 Hirschsprung's disease patients, of which 11% of the men had moderate or severe erectile dysfunction. If you look at the normal rate for moderate or severe erectile dysfunction in the control group, so the patients without, men without Hirschsprung's disease, that's about 8%. So this is a little bit higher. We were very concerned actually about the female sexual dysfunction and distress, because almost half, 53%, has dysfunction and 20% distress. Also, 60% of the patients said there was a need for better addressing sexual concerns during medical care. They said, we have never spoken about it, and I definitely would have wanted that. The other study, we had 27 Hirschsprung's disease patients. The erectile dysfunction was lower, only 4.4%, but the female sexual dysfunction and distress was about the same, 50% dysfunction and 37.5% distress. We also looked in this study, are there predicting factors? And what we saw that was reduced perceived self-competence in female adolescents was associated with more sexual distress in adulthood. And reduced perceived self-competence in romantic relations and friendships in male adolescents were also associated with reduced sexual desire in adulthood. Another study investigated the sexual functions after the anorectal pull-through for Hirschsprung, and they said that the newer techniques actually, that male patients reported similar sexual satisfaction and erectile function compared to controls. I have to add that for you, the first two studies I just showed on sexuality were older patients, so there were a lot of Radboud procedures still, and a lot of dual procedures. They found as well that females were currently in less stable relationship compared to controls, but they did not say anything about sexual distress. And the last study from England, sexual function, quality of life and fertility in women who had surgery for neonatal Hirschsprung's disease. 50% of those women reported dyspareunia. And of the 17 women, 47 conceived spontaneously and 17% after IVF. But the thing that was again the fact that was that women reported significantly lower sexual quality of life than controls. With all this information, what should we do with it? Should we do something with it? Should we change our outpatient clinic? Should we change our follow-up? Those are all the questions we can answer. But first, the conclusions on the health-related quality of life. Overall, you see improvement in bowel function with increasing age. I think that is really important to remember. What is important to remember as well is that we've seen now in the studies, in actually almost all studies from the last 20 years, that generic quality of life, so satisfaction and dissatisfaction, is not negatively influenced by the disease. But disease-specific complaints impair several domains of health-related quality of life. So that domain physical, social well-being, general health, self-esteem. And what we see is that maladaptive coping strategies also are related to worse mental health related quality of life. So follow-up is needed in all patients, and preferably in a multidisciplinary approach. For sexuality, the conclusions are that erectile dysfunction can be a problem. Almost half of all female patients suffer from sexual dysfunction and sexual distress. And reduced perceived self-competence in adolescence is associated with problems in sexuality in adulthood. So during adolescence, we have to do something maybe, or talk about it. After modern treatments for Hirschsprung, there are possibly less complication on the sexual area. But many patients feel that no attention is being paid during all those years they see the doctor. And this was not in this study, but it was a study in the ARMNet which said that many pediatric surgeons need advice and help in the conversation about sexuality. So maybe you can actually create a multidisciplinary team with a psychologist who can talk about it, or a sexuologist. They can all help you with that. And there are, of course, there are some tricks about it. What I do, for example, when the child is 12 years old and they're in my outpatient clinic, the next 12 or 13, the next visit will be somewhere around 15. And then I will tell you that that is going to be a subject which we're going to talk about the next time. And then, of course, they're 12 or 13, so they're laughing at you a little bit and looking at their parents. But yeah, you have to tell them that you're going to tell it. And actually, this was a tip I got from a patient. So an adult patient. And when they're 15, yes, they want to hear something about it. most of the time, but they find it still a bit strange that their doctor is talking to them about sex. But the funny thing is that when you see them at 17 and 18 years old, they know that it is a subject they can talk to you about. So if you do the outpatient clinic, then, for example, half with parents and half without, they feel quite free to talk about it. But what are the goals for you now? What are your goals in the outpatient clinic? What are your goals in the clinic? I think it's the most important thing to define the needs of a patient and the needs of your patient and the needs of his or her family, because they're in a social system and you have to look at the entire social system and discuss those needs. Just put it out on the table with your patient, discuss it. Do you need help? Do you want help? How do you want help? And provide patients and families then with possible interventions for improving their psychosocial functioning. For example, psychology. And that is why I think it is good to create a multidisciplinary team in your hospital. They don't have to be in the same room at the same time every outpatient visit, but you have to have them with you. They have to understand the disease and they should be able to perform a consult for you if that's necessary. And create a good transition to adult care. And also that are very, very many forms for that. But create a good transition for people who need it. And now, after saying this, I would like to do the poll again, actually. So the first question is, will you systematically evaluate quality of life in your patients after hearing this? And maybe I should focus ask the question a little bit different. Do you want to evaluate health-related quality of life in your patients?
I will close the poll in a few seconds, so please do vote. Well, I think you did a good job because now 95% said yes good. On this question.
Perfect. And the multidisciplinary team, will you try to create that? And again, it can be in several forms, in several ways.
And here 90% says yes. So it's increased.
It's increased. And will you provide the follow-up to your patients until they're 18 years old?
Here we've got 82% that says yes.
All right. And will you arrange a transition to care in adult life?
So now we've got a 95% that says yes.
Great. And because of the temperatures in Europe at the moment, I thought this one was suitable. So I'm happy to answer questions if you have any. Thank you for your attention.
Well, thank you very much, Marieke. Darren, I don't know if there's any questions on the screen. It's very interesting, but maybe Marieke, we should divide it a little bit again on talk a little bit more on sexuality and talk a little bit more on quality of life, although these are of course related. It is kind of shocking to hear, I guess, for many people, that particularly for women, like 50, almost half of them have a reduced sexual well-being, let's say, or sexual functioning or sexual well-being that is reported. And why is there a difference between male and female, or is it just underreported in the male, or is there a true difference? What do you think?
There is also a difference in the questionnaires that are used and the questionnaires that are available for this. The questionnaires that are there for males are mostly about functioning, and the questionnaires that are there about distress for women are more about the distress and the dysfunction and pain and everything. I do think that if you ask the same question to the normal population, which didn't have operations as well, the amount of females that had sexual distress or dysfunction will be higher than in males. It will be around 20 to 25%, but it's still double in patients with Hirschsprung's disease. So if you ask the patients what they are actually worried about, is that they will, when they're having sexual intercourse, that they will lose, for example, lose gas, lose feces, and that's why they have stress continuously during sexual intercourse and are not able to relax and have a normal sexual life. So those are the problems they are actually encountering. We don't have that validated questionnaire for the males. We did not use that, and to my knowledge, there is none. But I think it's very good to see what is the distress in males as well. If we would have a questionnaire, it must be there as well.
Yeah, and then because it was related to a reduced perceived self-competence, this is what you mean with that they are afraid for all kind of accidents that may happen during sexual activity. How should we, as a healthcare provider, deal with it? Should we try to have people cope with it psychologically or whatever, or should we deal with it that we have tried to improve the functional outcome, meaning, or maybe both? I don't know. Yeah. What do you think?
I think it should be both in the end, but that's why I think it is so important to talk to the patients starting at the age of 12 or 13 about this subject. They have to know that any problem they encounter in that area can be a result of their disease and the operations they had in that area. And a lot of people, if you don't ask for it, they won't tell you. They definitely won't tell you. So ask for it, and if there are any problems, yes, of course, you can go both ways. I think there is one path you should walk with, maybe for male and a urologist and a sexuologist, and for the females with a gynecologist and the sexuologist. I think that's very important to have them in your team. And on the other hand, when there are functional problems which this patient encounters all the time, yes, of course, we should focus on better bowel management to make them clean and make them be less afraid of problems. What you see when we did a research on adult patients that had not been to doctors for many, many years is that many problems became their normal life. Well, we actually a couple of months ago, we saw a patient together who was 50 years old, and she has a lot of problems which are just her normal way of life, but it's not normal, and you can, hopefully you can improve it with, for example, good bowel management.
Yes, and it starts early in during your during childhood, and with us as pediatric surgeons. But like yes. everybody says now, okay, I will follow up my patients till 18, and I think 95% now will have adult care as well. It shows that it is, I think, important. I also know that it's very difficult in the Netherlands, difficult to find the right people to take care of these patients and to take care of the problems. But it's good to hear that everybody is looking for it or has a program.
Yeah, it's exactly what you say, Ivo. It's difficult, and that is because we are pediatric surgeons. We treated the patient, we have seen the patient growing up, and we don't mind seeing the patients and talk with them about their function. But every adult surgeon is getting quite annoyed after 3 times seeing a patient and only talking, and there's no way to surgery or whatever. And then they say, well, you don't need me, you need a gastroenterologist, for example, and the gastroenterologist says, I don't know. So yes, it is always difficult to find the right surgeon or gastroenterologist, but I think it is important when you have patients that need it. I also have patients in my clinic which are actually sitting in front of me the last 3 visits at 12, 15, and 17 or 18 and thinking, why am I even in the hospital? I actually don't know that I have a disease and that I've been treated. Why should I go to a doctor that I don't know? And what I right now did for those patients, and I think there's a big difference between anorectal malformation patients and Hirschsprung's disease patients, especially what we saw in this presentation as well, that functional problems will diminish in later life, will reduce. So a lot of patients you have don't have problems anymore. What I do with them now is that they can always come back to me. So parents and the patient knows how to reach me again. And I'm asking them, do you want to come back in, for example, 5 years, or shall I phone you in 5 years just to see how you're doing and to see if you have any needs? And it has resulted now in patients who did not have any problems to phoned me a couple of years later, like, okay, I do need advice. What shall I do? Patients who are still on bowel management, a lot of laxatives, have a lot of problems. Yes, you should have a good adult care team for them. And one of the most important things as well, and I'm very grateful that we have a colleague now who is a surgeon for adults and also a fellow in pediatric surgery, that you need surgeons in your country. And an adult doesn't care if he has to travel for 2 or 3 hours to a place, but you need an adult surgeon who knows what a duhamel has been, who knows what a rabine has been, who knows what a pull-through has been, when they need another operation or when they have such big complaints that they need to be reoperated.
Yes, you need a dedicated team. Yes.
Yeah.
Just another, because you spoke, I see patients in front of me who have no problem. If I go back to the quality of life, per se, what do you think we should do? Should we check quality of life every year, every 4 years, every 5? Should we do it with every patient? Other patient groups maybe we don't need to check, or should we just check patients with functional problems? Because it seems that the functional problems are related to the health-related, reduced health-related quality of life, and not a general decreased general quality of life. Should we just focus on a group, or you think we should do it for everyone? Because it's a lot of work as well.
Yeah. Yes, it is a lot of work, and I do think the data that we've seen, I think you should not focus for every patient on the generic quality of life. I do believe that it is good to check health-related quality of life with a simple questionnaire. It should not take your patient 30 minutes or 40 minutes, but I think it is good. And the best way to do it, actually, and that is so difficult to arrange, is that they have the questionnaires filled out before their outpatient visit. And if they're in the outpatient clinic, then you can actually go through their results. And the best way is actually to compare them to other patients. And sometimes when you ask your patients, as a doctor, which they've known for many years, do you have problems? They won't say it, but sometimes there are little things that are going to be in the health-related quality of life questionnaire. So yes, I do think that you should do it actually for all the patients, but not every year. I would maybe do that like every 2 years, because I do think you need some extra way of signaling if there are problems which are not mentioned.
And in a way, it shows whether the patients are able to cope. If you compare it with their functional outcome, it shows you whether they're able to cope or need help, more help to cope with maybe worse functional outcome, I guess.
Yes, yeah, that's true. And recently I saw actually a quite good questionnaire which is focused on coping, and I know you are going to ask me how it's called, and I don't know that at this moment, so I can put it somewhere in the in an email or whatever. That's no problem. But there is a questionnaire on coping, and I think that one is quite good to identify if there are problems.
The coping mechanisms. Okay. Yeah. Darren, are there any, because I can't see anything on our list. Sometimes we get the questions asked by the audience. I don't know if there are any questions, Darren.
Yeah, I tried to send it through to you, but I will, yes, no problem. I will read them out loud because Stephanie Martshäuser, she asked, we actively motivate patients to contact peers in self-help groups. Do you recommend it for your patients?
Yes, we have good patient groups here in the Netherlands for Hirschsprung's disease and for the anorectal malformations, and yes, we do promote it. I do see that a lot of people are quite, when their child is just diagnosed with the disease, there's a lot going on. It's a roller coaster in their life, and then they're also introduced, well, there is a patient organization and you can go to it. I do hear back from a lot of patients that when they enter it, then it's quite overwhelming because, of course, there are a lot of people who still have problems. But in the end, a lot of people are very satisfied with it. And what I really like as well is that the patient group for Hirschsprung's disease and the anorectal malformations both have also weekends for patients, and they go on a campsite or whatever together. And they all have the same problem, and they can learn from each other and they can talk to each other. So I think it's very important.
It helps coping as well. I think it can help a lot. In the right time and the right place. Right. Luz, any further questions?
No, that's it. I didn't receive any other questions. I think you covered a lot of the probable questions.
Topics, okay.
Yeah.
Maybe Marieke wants to give a last remark, or no?
No, I actually really liked it, and I like that 40 plus people, physicians, nurses, I don't know who is all there, but that you joined this because of course we're pediatric surgeons and we love to operate, but the thing that's coming, the next steps and growing up of your patients is very important. So think about that in the entire process.
Yes, I completely agree. It's part of our job. Thank you very much, Marieke. Thank you, Luz, as well. So everybody have a good evening. And thank you for being with us. Goodbye.
Thank you both. I would briefly want to mention that our webinar has been recorded and will be available on the GoToWebinar platform and the YouTube channel. And after the webinar closes down, there will be a survey. We would kindly ask you to fill them in to help us continuously improve the sessions. And for now, thank you very much. Have a nice evening and take care. Goodbye.
Goodbye.
Bye-bye. Thank you.